All right, good morning. Welcome to Psyfeld. This morning's episode is the Serenity Now. So, any observations? Where would the group like to start?
The screaming of Serenity Now. I would think that it's more of like an emotional, maybe just regulation or maladaptation, just because it's meant to lower his blood pressure, kind of put him in a serene and calm environment, but instead he's yelling it and it seems to make him more frustrated. So I thought that was really interesting.
Yeah. So, any advice to Larry David? Not that he would ever do this, because then we wouldn't have the comedic outcome that we do. But in real life, if this were something that might be initiated, any advice as to where this task or technique went wrong and what you would probably add or recommend?
When he's saying Serenity Now, he's saying it like in a very loud voice. It just can be seen as like he's kind of like feeling those emotions, and so he kind of could create a cognitive dissonance. So if he could do it like quieter or in a calmer context, I feel like it would serve a better purpose to help him calm down rather than get excited.
Yeah. So let's say we have a cohort of 100, play with even numbers, of individuals who are using this technique who have the adverse outcome that Mr. Costanza does. And then with that adjustment, we're gonna half that. That's a 50% improvement. Any thoughts of what we're going to do with the other half? So the individual who, from now a cohort of 50, who still is utilizing Serenity Now in a calmer voice, but is still experiencing adverse outcomes. Any thoughts there? And the answer is not medication. So I think this technique parallels what we often refer to as thought stopping when it comes to cognitive behavioral therapy, where an individual has an adverse thought and they just deflect from that thought by using anything, right? So it could be simple thought stopping as a technique where the individual's inner voice is stop, or Serenity Now, which is basically stop. What may be missing though is filling that void with something positive, like an affirmation. And that's where I think another cognitive behavioral technique, you mentioned cognitive dissonance, with regard to challenging yourself as to why you're reacting the way you are, because sometimes those automatic thoughts are not reality based, right? If I don't sleep, if I don't get 8 hours, and if I don't get enough sleep, I'll never be able to work tomorrow, right? That catastrophizing is something that could be challenged, right? So that's something to consider here. That is, thought stopping in general might be just the initial part of a two-part process, right? And that second part may be challenging those automatic thoughts. Right. Any other observations for, we'll just keep it focused on Mr. Costanza for now. Any other thoughts here? Pardon the fun.
Maybe he's like displacing, like he's using like displacement in a way because he's putting all these feelings into one another and not really, as you said, adjusting or handling those thoughts head on.
Yeah. So, I mean, maybe in addition to providing cognitive behavioral therapy, maybe other forms of therapy, interpersonal, even psychodynamic therapy to get at maladaptive defenses that are part of this as well. These different ideas that we have in terms of how to approach a patient in psychotherapy are not mutually exclusive, even though they're taught that way to the next generation of physicians. Right? We can easily employ concepts from, let's say, converging, although again in the textbook it's usually diverging, really converging theories of the way people act and behave, right? And in this case it will be cognitive behavioral as well as psychodynamic, for example. Yeah. Other characters that caught your eye in the episode The Serenity Now?
Well, Jerry's little plot is very interesting in that the girl of the flavor of the moment that he's dating likes him when he's angry and showing emotion, and Jerry's someone who generally doesn't is very I won't say self-serving, not a very emotional person. And at one point he manages to get a feeling of anger out towards her. She likes it. He continues. And she's like, this is too much. And then he displays a whole lot of emotions towards friends and family members that he hasn't displayed before. And it's too much. This is not what they know of Jerry. And so it becomes uncomfortable for everyone around him. And it takes a downloading of George of his own for him to snap back from this over emotional moment that he has in the episode.
And let's say that occurs to a point where, as you've recognized and observed, it results in clinically significant distress, or some kind of a impairment in functioning for Jerry, to the point where he comes comes to clinical attention. He actually comes for help, right? And you're that clerk, you're that psychiatry clerk, you're that future psychiatrist, and he asks Doc, quote, "What is wrong with me?" End quote. Right, so at the end of your psychiatric evaluation, what's some feedback that you could provide to Jerry in as much as building a treatment plan? What are you going to do for him?
You benefit from CBT. Like, I think if, like, telling them that like emotions are allowed to be felt, that they can be distressing if you bottle them up, and they can be more intense than you would if you just express them when you felt them. And that if he can learn how to more healthily, I don't know if that's a word, but kind of express these emotions, that he might be less distressed and kind of find that middle ground between, like, this intense love he felt toward Elaine all of a sudden where he like proposes to her, where it wasn't like, probably that's not how he felt, but because he's been bottling up for so long, it was intensified. So teaching him kind of ways to adapt and cope with those feelings, and to how to express them in a way that he's not always suppressing how he feels.
Right. I agree with you. I think CBT would be the most likely referral. Is there another referral to another form of psychotherapy that you'd consider, and why? And you actually already gave the why. So the hint, it's more than a hint. The answer was already provided in terms of what you described.
I guess maybe psychodynamic, like him being able to express his emotions to other people inside without it becoming overwhelming for him.
And if that's true, why is it that Jerry Seinfeld, the character, was unable to express his emotions prior to your intervention?
I don't actually wonder if there's like some component of like social anxiety that makes he's afraid of being judged by the other people. Like they have this view of him that is very cool and above it all, and then he's afraid of being real and then being rejected.
And I think in your notes from the primary interaction from that psychiatric evaluation, the initial assessment, you'll probably jot down social anxiety disorder, perhaps even avoidant personality disorder. But the feedback that you're providing in terms of dynamic psychotherapy, I think, is accurate. Why is it that Jerry Seinfeld, up to this point, again, Jerry Seinfeld, the character, up to this point, is not able to express his emotions? He's going to ask you, Doc, why psychodynamic psychotherapy? Isn't that like outdated? What feedback are you going to provide him? He's got a maladaptive ego, right? His ego defenses are not working, right? So likely repression, perhaps denial, but they appear rigid. And the one time that he's able to overcome that, you could see the flooding, right? That's the problem. So we need to teach Jerry Seinfeld, the character, that he needs to be more flexible with regard to the defense mechanisms that he utilizes to allow those impulses to come to conscious awareness, because what he's doing is not working. Oh, by the way, I guess neither is humor, which is considered to be a quote unquote mature defense. I mean, he utilizes that literally in every episode. So it's not the defense mechanism per se, but it's the rigidity within which he uses the few. We have to expand that lot. And that's psychodynamic psychotherapy, right? So you explained it, right? You nailed it. Yep. Any other observations for Jerry Seinfeld here in this subplot? What other characters you want to discuss this morning?
So like the bar mitzvah, I can't remember his name, the kid and the dad, they kind of acted on impulsivity instead of like appreciating social norms. Like you don't just randomly like jump across the couch and kiss somebody. So I thought that was interesting. I'm not really sure where it would stem from, but it was just interesting to see that impulse both in the child and the dad.
Yeah. 2 or 3 things at this point in your psychiatric evaluation of either character that you have in your short list you want to address during your initial assessment. So you already said one, and you weren't sure where it comes from. We have to figure out where it's coming from. That is, we have to evaluate for another disorder. I think in your psychiatric assessment, that's routine, right? That's built in. And I want to hear words like bipolar, major depression, etc. In as much as you provided that psychological review of systems, right? What signs and symptoms are manifest, not necessarily in the HPI, but past psychiatric history, that might be consistent with a diagnosis that might actually explain why it is we're seeing what we're seeing. And the other thing I want to know is, well, two more things. Number one is persistence. Is this recurrent, or is this just a behavior in a vacuum, right? Because if it's just happened once, sure, the individual should be reprimanded. But beyond that, I'm not so sure there's psychiatric intervention. However, if it is recurrent, that final question is, does it result in clinically significant distress or impairment? Because if so, we're going to use the word disorder in terms of what we're looking for, and that piggybacks where we started this, and that is, what does your psychological or psychiatric review systems tell us? Is there SIGIT caps? Is there dig fast? Is there anxiety? Is there psychosis, etc.? If none of the above, but recurrent and clinically significant, we're in a chapter that was previously known as the impulse control disorders. And then now the chapter went through a name change as of 2014, that is the DSM-5, to include two conditions from child adolescence, and that is ODD, oppositional defiant disorder, as well as conduct disorders. And for the child, we can definitely discuss that. But because none of us here are child adolescent psychiatrists, we're going to just refer that out. There are three other conditions left in this chapter that for adults we should discuss, not necessarily because of the character demonstrating these signs and symptoms, but we have to make sure that the characters do not display those signs and symptoms that would allow us to diagnose one of these three conditions in this chapter. So other than ODD and conduct disorder, what are the other three conditions in this chapter formerly known as the impulse control disorders?
Antisocial personality.
Now that's in the personality disorder chapter.
Intermittently explosive
All
disorder.
right, so that's one, right? So now we're looking at the adult in this episode. Any evidence of intermittent explosive behavior? Doesn't appear so, right? I'm taking the pause, the collective pause as a probably not, all right? Two other conditions. Now, despite that, much more importantly, it can show up on a shelf exam, right? And for intermittent explosive disorder, you have these anger outbursts that are usually, or by definition, in excess to the actual prompt or stimulus, and clinically significant, and not due to the effects of a substance, an underlying condition, or otherwise classified or elsewhere classified, meaning another mental disorder within which impulsivity is part, bipolar, etc. Antisocial. So that's the number one consideration. There are two other conditions to discuss here. The impulse control disorder. What happens when an individual describes as irresistible impulse?
Tick
Kleptomania.
disorder.
Kleptomania.
Kleptomania, right? Where it's the impulse to steal, right? Now, and let's say somebody actually demonstrates such behavior. I don't think our character in this particular episode does, but in a shelf exam, they will. So, how do you differentiate choice A, kleptomania, from choice B, shoplifting?
Because they have an urge. So, like, for example, if someone feels like the urge that they have to steal, but they feel bad about it with no ill intent, then it's kleptomania. If they feel that they're stealing for gain, then it's most likely shoplifting.
And for gain is by far the single most important thing, right? The individual who steals secondary or as a result of kleptomania will have to actually demonstrate motiveless behavior. And if there's motive, for example, the value of the object or the item that they stole, it is not kleptomania, and it's more likely shoplifting. What's the third and final condition? Pyromania, right? So now we're just exchanging out stealing with fire setting. So describe to me the difference. Choice A, pyromania, single best answer on a shelf, versus arson.
Someone's doing it for like release, like to feel better, it's pyromania. If someone's doing it because they want to cause harm to others, then it's going to be arson or probably a conduct disorder, antisocial personality disorder.
Talk to me a little bit more about that second part. It's motiveless. Again, motiveless. If the individual sets fires and that fire setting is motiveless, if it's only because of that irresistible urge, it's called pyromania. If there's motive, like the insurance money you're going to get from the store burning down, then it cannot be pyromania, and it's probably arson. Any questions about these conditions, at least the adult conditions of pyromania, kleptomania, and intermittent explosive disorder as published in the DSM-5? I don't think any are in the conversation here with regard to the behavior that we saw in this episode, but somewhat likely to actually see this on your shelf exam. 5 minutes left. Any other interaction, any other scene or character you want to discuss from the Serenity Now?
I was thinking about that point to son, George, I think is his name, and how he kind of might be displaying a dependency where all of a sudden he feels like he needs to prove himself to his parents because of everything that they said to him, and so then he buys all these computers and kind of does things that are, maybe not the most financially wise for him. He ends up in a lot of trouble at the end with all these.
Yes, there's a lot to unpack there. We know that George has a maladaptive relationship with both of his parents, Frank and Estelle. There's no doubt about that. We have, even though it may not be clear in this episode, there are multiple episodes where we actually get flashbacks. We get peeks into George as a child, whether it's verbal, whether it's even some audio when George is a little boy. We also know that those interactions as a child certainly affect George as an adult, not only the interaction with his parents, but clearly the interaction and intimate relationships as well. And all of the above is true. So along those lines, we're focusing on this particular episode, and we see someone trying to win over his father's favor. But then again, it's for all the wrong reasons. There's no self-reflection. It has everything to do with them disliking Lloyd and therefore liking him almost as a default, which needs to be explored. I don't have the answer for you here. This is a very complex, but it's more to distract his father from liking someone other than me, rather than liking me, which is interesting. Certainly something that would be, again, addressed in therapy probably. Now, there's no medication that's going to touch this. Any other thoughts on that, anybody? All right, we'll leave it here.